And the second question actually we want to ask is Dr. Gong and Dr. Trapani. So we ask about the Ascender 4 and Ascender 3 research. We also know the TROPION-Breast 2 trials makes the makes the triple-negative breast cancer into the first-line ADC era. So based on this starting date, how will the single agenda Dato-DXd specializedly reshape our clinical pathway? So first, we want to ask Dr. Gong to answer the question. I understand you also have a question to ask about the Dr. Trapani. Yeah, thank you so much.
Thank you for the kind invitation from Professor Hu and Professor Wang. It's my pleasure to be here. Professor Trapani has outlined where we are and how quickly the field is evolving in the treatment of triple-negative breast cancer. And building on that, I will focus on the specific question of how recent TROP2 ADC data changed the way we treat first-line triple-negative breast cancer. First, we have to admit that in the first-line triple-negative breast cancer, the majority of patients are not suitable for immunotherapy. And with the approval of KEYNOTE-522, more patients are now receiving immunotherapy in the early stage. So this pretreated population is steadily growing. That means more than half of our patients still requires a non-immuno treatment backbone. So the question is, should chemo or ADC be our starting point? And this is exactly the space addressed by TROPION-Breast 02 and ASCENT 03, of course. Both phase 3 trials have shown that single-agent ADC outperform our standard chemotherapy in immunotherapy ineligible first-line TNBC. Since Professor Trapani has already reviewed the trial's results in detail, I won't repeat that. I will focus on the points that are most relevant to our clinical decision-making. So first is population difference. TB02 tested Dato-DXd in a population with more early resistant biology, and more patients with a very short DFI of 0 to 6 months. So ASCENT 03 requires a DFI of more than 6 months. And second, the control arm matters. In TB02, the control group mainly received single-agent taxane. In ASCENT 03, however, about half patients in the control arm received Gem-Cabo, which is generally considered to be more active. And that difference affects of how we interpret the results. In terms of response, Dato-DXd achieved an ORR of more than 60%, and that's suggesting a rapid tumor shrinkage. And safety is also ADC, where ADC really changed the game. Dato-DXd showed a lower rate of grade 3 adverse events, around 30%, compared with SG, which is closer to 60%. And this places Dato-DXd between a single-agent chemo and combinational chemotherapy in terms of severe toxicity. However, the toxicity profile is different. With Dato-DXd, the dominant issues are stomatitis, ocular surface disorders, and LD, of course. SG, on the other hand, behaves more like our traditional chemotherapy with high rates of trophonia and diarrhea. So when choosing between ADCs, it's also about which toxicity pattern better fits our patients. And there are also practical reasons. Dato-DXd is given as a short infusion time every 3 weeks without multi-day schedules, which would improve our patients' convenience. Our next question is what happens next? So if a patient receives a first-line Dato, can we still use T-DXd later? Maybe we should think about the overlapping pulmonary toxicity. Sequencing between ADC with different payloads sounds to be a much safer choice. So I'd like to hear Professor Trapani's perspectives of where he thinks where this is heading. And finally, we must come back to our clinical reality. That is, all of this data suggests a major shift in treatment strategy. These drugs are not yet being approved in the first-line settings, and the cost remains a major issue. One final point is I noticed that across many studies, the platinum-based chemotherapy continues to show meaningful activities. I see that in ASCENT 03, the Gem-Cabo subgroup showed no clear separation, with a median PFS of 8.5 versus 8.1 months. Also, in the KEYNOTE-355, the Gem-Cabo treated patient has an identical PFS of 7.4 months in both arms. And looking back to the GAP study led by Professor Hu, the AP regimen, that is nab-paclitaxel plus cisplatin, achieved an ORR of 80%, a PFS of 9.8%, and OS of 26 months. Of course, we know that cross-trial comparison is not it must be cautious. But if we simply look at the numbers, its results remain impressive even in the ADC era. So I have a question for Professor Trapani that I would be interested in your view of how to understand the findings of this subgroup in both ASCENT-03 and KEYNOTE-355, that in the GC subgroup, there's no clear separation of PFS. And how do you currently view the role of platinum-based chemotherapy in the first-line treatment of triple-negative breast cancer? Thank you.
Yeah, thanks really, Dr. Gong, for these amazing, questions. And I think first was how to overcome, and if we should overcome platinum-based chemotherapy in the front line. And the second was on the ADC sequencing. What happens if we move everything up front? So to reply to the first question, I should say that usually, the most tangible data that we have in the upfront use of carboplatin for triple-negative breast cancer is essentially in the BRCA mutated tumors. We have a pivotal clinical trial from UK, that's the TNT, in which it was very clear that providing carboplatin was superior to docetaxel upfront. But it's not really true that providing to all patients the carboplatin upfront, regardless, HRD status and BRCA, is really the best choice. And in fact, we consider in the clinical practice a first-line taxane-based chemotherapy, as standard of care as a clinical practice. And also we combine carboplatin gemcitabine when we have, resistance to taxane or when we have clinical need to shrink the tumor quickly because of the tumor burden. So overall, like the upfront choice for carboplatin is really clinically based. I'm not sure there is any, urgent, need to still keep such a chemotherapy choice for all the patients, unless they have a BRCA mutation or a specific platinum sensitivity, that's intrinsic. I also agree with you that the subgroup analysis of ASCENT-03 and 04 in particular still keep some kind of, doubts on how we should incorporate ADC upfront. But the problem with this clinical data is that there are subgroup analyses. Some of them were pre-specified stratified subgroups, but some of them were not. And there are some imbalances in previous exposure to immunotherapy. So I think that the only way to disclose such a meaning across the subgroup analysis is to provide full adjusted, as based on multivariable models of the subgroups, because as we report in the clinical trial, as a univariate comparison, this has no really clinical indication. We cannot really translate, in the subgroup analysis, the clinical practice. What we see is the trend. And if we have any strong signals, as you point out, in one of the subgroup, we should validate in a controlled clinical trial because we have to make sure that the signal is validated. We don't usually inform clinical practice on the subgroups unless you have a very strong rationale. And in this case, I think we don't really have, because ASCENT-03 and 04 have a very different impact of the ADC upfront on the chemo-resistant tumors. And so we don't know how to interpret these divergences across the subset. The second question that you did was about ADC sequencing, and here we are in the data-free zone. Everything we have is real-life, real-world evidence that show that probably if we tackle the same cellular target, in particular the topoisomerase 1, you don't really result in any benefit in these patients with a PFS in the sequence that may be between 2 and 3 months. But then if we move everything in the upfront, we should think about innovation and new agents that are able and capable to overcome. And this is really a matter of the clinical practice. Whether ADC upfront improve the overall survival, it does mean we're changing the natural history of these patients. If the sequence is more appropriate, we will discover definitely in the secondary analysis of these clinical trials.
Okay, thank you for your insightful answer.
All right. Do we have another question, or this is and I don't remember. Perhaps